This is Dr. Shakil Ahmed. Uh, Today I will discuss liver cirrhosis. The World Health Organization has defined the liver cirrhosis as a diffuse process characterized by fibrosis and the conversion of the normal liver architecture into structurally abnormal nodules. Basically, three major pathological mechanisms combine to create cirrhosis. First of all, cell death. Second, replacement by fibrosis. And finally, there is regeneration. Cirrhosis has been classified as micronodular and macronodular. Only the size of the nodules, or if smaller, less than 10 millimeter, will be called micronodular, and if the size or more than 10 millimeter up to 50 millimeter, it will be called macronodular. Causes: alcohol consumption is one of the most common cause of micronodular cirrhosis, while chronic viral hepatitis is the cause of macronodular cirrhosis. Other causes, they are listed as biliary cirrhosis, whether that is primary or secondary, Wilson diseases, primary sclerosing cholangitis, hematochromatosis. The classic clinical presentation of cirrhosis is hepatomegaly jaundice ascites. However, serious liver injury may be present without any clinical clues. In fact, only 60% of patients with cirrhosis have signs and symptoms of liver diseases. Cirrhosis has serious prognostic implications, and patient may succumb to progressive liver failure and the sequelae of portal hypertension. They also have a greatly increased or development of HCC. Sonography holds great clinical interest. The morphologic pattern associated with cirrhosis are, first of all, volume redistribution. In early stages, the hepatomegaly is observed, while in advanced stages, the liver is becoming smaller. Relative enlargement of the caudate lobe, left lobe, or both compared with the left lobe is revealed. The ratio of the caudate lobe width to the right lobe width is an indicator of cirrhosis. A ratio value of 0.65 is considered indicative of cirrhosis. The specificity is high, 100%, but the sensitivity is low, that is 43 to 84%, indicating that the ratio is a useful measurement if it is abnormal. The second finding on ultrasound, coarse echotexture. Increased echogenicity in coarse echotexture or frequent observation in diffuse liver diseases. These are subjective findings and may be seen by inappropriate TGC setting in overall gain, time gain compensation. Nodular surface. Irregular surface is a sign of cirrhosis. When the appearance is gross or when ascites is present. The nodularity corresponds to the presence of the regenerating nodules and fibrosis. Regenerating nodules. These regenerating hypocytes are surrounded by fibrotic septae. Regenerating nodules have a similar architecture to the normal liver. Ultrasound and CT have limited ability to detect them. Regenerating nodules tends to be isoechoic or hypoechoic with a thin echogenic border that corresponds to fibrofatty connective tissue. Dysplastic nodules or adenomatous hyperplastic nodules are larger than regenerating nodules, that is more than 10 millimeter, and are considered pre-malignant. They contain well-differentiated hepatocytes, a portal venous blood flow supply, and atypical or frankly malignant cells. The portal venous blood supply can be detected with CD and distinguished from the hepatic artery supplied HCC. Patient with cirrhosis and liver mass, ultrasound-guided true-cut biopsy is often performed to exclude or diagnose hepatocellular carcinoma. This is the image which shows coarse parenchyma, and there are innumerable tiny hypoechoic nodules. The ecotexture is heterogeneous. This image also shows coarse parenchyma and innumerable hyperechoic nodules. There are hypoechoic nodules also present. This is another image of coarse parenchyma and surface nodularity. The surface of the liver is irregular. This is the image which shows a large caudate lobe and a smaller right lobe. This is the right lobe, which is small, and the left lateral segment is enlarged. This image shows small right lobe of the liver and enlargement of the left lobe of the liver, and that is separated by the main lobar fissure. This image shows small end-stage liver with surface nodularity, and that is very well appreciated when the patient also suffers from ascites. The irregular surface is very clearly appreciated. This is the liver with large nodule protruding from the deep liver border. The outline is irregular. Thank you very much for being with me. Hope that some messages are delivered, especially to the new sonologist.